Welcome to DoodleMed Insights.
Anemia is a condition marked by the following features. Hematocrit less than 41% in men, or less than 36% in women, or hemoglobin less than 13.5 gram per deciliter in men, or less than 12 gram per deciliter in women. Anemias are most easily classified according to their cell size. Microcytic anemia means a low mean corpuscular volume less than 80. These are most commonly a result of iron deficiency, anemia of chronic disease, thalassemia, sideroblastosis, and lead poisoning. Anemia of chronic disease can be either microcytic or normocytic. Macrocytic anemia is characterized by an elevated mean corpuscular volume more than 100. This is most commonly from vitamin B12 or folic acid deficiency, but can also result from the toxic effects of alcohol, liver disease, or chemotherapeutic agents such as methotrexate or medications such as zidovudine or phenytoin. Normocytic anemia is characterized by a normal mean corpuscular volume. This can be from an early form of the conditions such as iron deficiency and anemia of chronic disease, as well as most forms of hemolysis and aplastic anemia. The predominant symptoms of anemia are based on the severity of the anemia rather than the specific etiology. Early symptoms include fatigue, tiredness, and poor exercise tolerance. As the anemia worsens, the patient develops dyspnea on exertion and lightheadedness. Eventually, confusion and altered mental status may develop as oxygen delivery to the brain decreases. Death from anemia is most often from decreased oxygen delivery to the heart, resulting in the development of myocardial ischemia. The severity of symptoms is related to the underlying condition of the patient. A healthy young patient may have no symptoms at all with hematocrit 27 to 29%, whereas an older patient with heart disease may develop dyspnea or anginal symptoms with the same hematocrit. Once a diagnosis of anemia is determined based on a low hematocrit or hemoglobin, the first step is to determine the MCV. Iron studies, reticulocyte count, peripheral smear, red cell distribution width, Coombs test, vitamin B12, folate levels, and even occasionally a bone marrow biopsy may be necessary to determine a specific etiology. The tests ordered depend on the specifics of the case presented. Let's start by addressing iron deficiency anemia, which is commonly associated with microcytic anemias. Anemia presenting with reduced red blood cell production and an MCV less than 80 marked by hypochromic cells and depleted iron stores. Iron deficiency anemia is almost always caused by blood loss. The most common type of blood loss is GI or menstrual. Iron absorption is tightly regulated. A man requires about 1 milligram per day and a woman about 2 to 3 milligrams per day on average. It is difficult for the body to increase the level of iron absorption. If there is even a modest increase in blood loss, occult blood in the stool, a heavier menstrual flow, or an increased demand such as during pregnancy, the body is poorly equipped to increase its level of absorption to exceed 3 to 4 milligrams per day. Other etiologies are increased urinary loss of blood, malabsorption, hemolysis, and poor oral intake. Mild anemia may result in absent or very limited symptoms. As the hematocrit approaches 30%, symptoms of fatigue and poor exercise tolerance may develop. As the hematocrit lowers to 25%, tachycardia, palpitations, dyspnea on exertion, and pallor develop. Older patients and those with coronary artery disease may become dyspneic at higher levels of hematocrit. More severe anemia results in lightheadedness, confusion, syncope, and chest pain. A systolic ejection murmur may develop in any patient with moderately severe anemia. These symptoms are not specific for iron deficiency anemia and may develop with any form of anemia provided it is sufficiently severe. Symptoms specific to iron deficiency are rare and cannot be relied upon to determine the diagnosis. These include brittle nails, spoon-shaped nails, glossitis, and pica. Iron deficiency anemia as a specific diagnosis is determined by laboratory findings, not symptoms. A low serum ferritin less than 10 nanograms per milliliters is the most characteristic finding of iron deficiency anemia. Low ferritin has good specificity but poor sensitivity. The ferritin level may be falsely elevated because it is an acute phase reactant and may be elevated in other inflammatory states or with malignancy. MCV is low except in very early cases. The serum iron is low and the total iron binding capacity is high. The red blood cell distribution width is elevated. The reticulocyte count is low. Platelet levels rise. The most specific test, although rarely necessary, is a bone marrow biopsy looking for stainable iron stores. Oral therapy with ferrous sulfate tablets is the most common method of therapy. Oral therapy should be continued until hemoglobin and hematocrit have normalized and an additional 2-3 months to restore iron stores. With replacement of iron, a brisk increase in reticulocytes will be seen 2 weeks into treatment. Parenteral iron is used in patients with malabsorption, kidney disease, or an intolerance to oral therapy. Blood transfusion is the most effective method of delivering iron but, of course, is not a standard method of correcting iron deficiency anemia except in cases with severe symptoms.
Thank you for your attention, and I hope you have gained valuable insight into this important topic.